Dana Willen. I am assistant professor in the Department of Pediatrics at UC Davis. I'm in the divisions of both hematology, oncology, and pulmonary medicine. And I'm going to be chatting a bit about airway function and sickle cell disease, and really looking at the impact in morbidity and mortality across the lifespan. I have no disclosures. So I just wanted to start with a Venn diagram just to help us visualize this interplay that we see between asthma, wheezing, atopy, and airway hyperresponsiveness for individuals with sickle cell disease. The definition of these entities has been really nebulous for individuals with sickle cell, and it's really unclear if asthma exists as a distinct comorbid condition or if there's more of this asthma-like syndrome, which is secondary to what we know as the hemolytic, pro-inflammatory, and the injured lung state that we know happens in patients with sickle cell disease. So we know that each of these separate entities can occur in conjunction or independent of asthma. So we're going to take some time and discuss some of the implications on the disease-related complications for individuals with sickle cell. And then I'm also just going to take a minute to discuss how lung function testing can be an important consideration. So we know that a diagnosis of asthma is associated with an increased risk for acute chest syndrome, which is a severe acute respiratory complication that's really specific to patients with sickle cell disease. So this figure shows results from pooled data from 3 really large pediatric sickle cell studies. So it includes a total of 1,685 children. And on the x-axis, we can see a diagnosis of asthma, for which in these studies was defined as a physician diagnosis in the medical record. And then on the y-axis, we have acute chest syndrome episodes per 100 patient years. And so we can see having a diagnosis of asthma is associated with an almost 2-fold increased risk for acute chest syndrome episodes. We can see really similar results for severe acute vaso-occlusive pain episodes, which is the most common complications that we see in patients with sickle cell. And this is data from the same pooled analysis. So again, on the x-axis, we have a diagnosis of asthma, and on the y-axis, pain episodes per 100 patient years. And this, again, we see an increased incidence rate for pain, which is 1.34. There's not been as clear of a connection between asthma and pain and acute chest syndrome in adult patients. But interestingly, clinical wheezing episode, and this is independent of asthma diagnosis, has been associated with an increased risk for pain and acute chest syndrome in adult patients with sickle cell. So in a study done at Mount Sinai, more than half of the patients with a history of wheezing did not actually carry a diagnosis of asthma. But in this study, they showed that a history of wheezing episodes was associated with 118% increase in ED visits for pain and 158% increase in the frequency of acute chest syndrome episodes. Additionally, recurrent severe wheezing episodes, which is defined as 2 or more attacks of wheezing that made the patient feel short of breath, has been associated with a more than 2-fold increased risk of hospitalizations for ACS and pain. So wheezing's been associated with ER visits and hospitalization for both pain and ACS in adult patients with sickle cell. In a study done in adult patients with sickle cell, and again, a history of wheezing, but without asthma, this study showed 8 weeks of inhaled mometasone therapy was associated with a reduction in daily pain scores, decreased cellular VCAM levels, and a decreased inflammatory markers, which is suggesting that inhaled corticosteroids may be a really good treatment option to mitigate some of the morbidity that we see in our patients with sickle cell lung complications. So moving on to explore atopy. So atopy, defined as a positive allergy skin test, has been associated with an increased risk for recurrent ACS episodes. So this is data from a retrospective case control study of 80 children with sickle cell and then 80 matched controls, and showing individuals with asthma were noted to have 6 times the odds of having recurrent ACS episodes, and that's compared to those without asthma. And then more specifically, when it was broken up to individuals with atopic asthma, and these individuals were noted to have 8 times the odds of having recurrent ACS than those without atopic asthma. The non-atopic asthma group was not associated with an increased odds of ACS, suggesting that atopy may really be the driving factor in these patients. So this was explored prospectively in a study of 168 children with sickle cell from the sleep and asthma cohort study. In this data, 41% of children had at least one positive allergy skin test, so a really high incidence of atopy. And then in the multivariable model, there was an additive significant effect of having a positive skin test on future rates of ACS, so that each increase of one positive skin test was associated with a 23% increased rate of future ACS episodes. So again, really suggesting that ATP may be a really important risk factor for acute chest syndrome episodes in children with sickle cell. Bronchial hyperreactivity in individuals with sickle cell appears to be higher than in the general population, and similarly has been seen in children and adults, and that's without a diagnosis of asthma. The connection that we see in disease-related complications hasn't been as clear. So in a study done of 15 adult patients, there was a correlation between the number of ACS episodes and having a positive methylcholine challenge. But in a cohort of children, so 70 children with sickle cell, they showed that methylcholine dose response slope was not found to be predictive of future risk for pain or ACS episodes. We know that children and adults with sickle cell do seem to have lung function impairment and compared to matched controls. So in this study, we can see that all of the lung function parameters are significantly different between sickle cell patients and the control group. While many of the parameters are still falling within the normal range, there is a consistently lower FEV1, FVC, the ratio of the FEV1 over FVC, the TLC, and then the DLCO and corrected DLCO. And then we do see a higher reserve volume in the sickle cell group than in the control group. We know that most children with sickle cell do tend to have lung function testing results in the normal range. And among those children who do have abnormal lung function, it does not seem that these patterns predict any sort of morbidity. So there's been no association between having an abnormal lung function pattern and future vaso-occlusive pain or acute chest syndrome episodes. But it is significant to know and understand that lung function parameters are impaired or decreased among individuals with sickle cell, because a low FEV1% predicted has been associated with earlier death. So this is a study of 427 adults with sickle cell with a mean age of about 32 years. And we, from this data, we do see that those with an FEV1% predicted less than 70% have an increased risk for earlier death when compared to those with an FEV1 greater than 70%. So from the Kaplan-Meier curve, we have follow-up time after the spirometry is done on the x-axis, and then cumulative survival on the y-axis. And there's a statistically significant increase in survival seen in this group with the FEV1% predicted less than 70%. And interestingly, in this study, neither the FEV1 over FVC ratio nor the TLC was associated with an increased risk for death. So we know that lung function is impaired in individuals with sickle cell, and that low FEV1% predicted is associated with earlier death. So with this data, we conducted a study to really investigate what factors may contribute to a decline in lung function, specifically in FEV1% predicted. So in this study, 197 children with sickle cell between 4 and 19 years of age were followed and had at least 3 spirometry measurements over a mean of about 5 years. And children were noted to have a very modest decline, so about 0.3% per year. But results from this multivariable model showed that age was the only clinical characteristic predictive of statistically significant decline. So none of the other characteristics, so looking at sex, hydroxyurea use, baseline hematologic parameters such as hemoglobin, white blood cell count, or reticulocyte count, the pain or ACS rate, none of these were found to be significant. And then interestingly, even though we know there's a really significant impact of asthma on morbidity and mortality, this parameter was not predictive of a decline in FEV1% predicted in this data. So while there is a modest decline in lung function seen in children, decline in adult patients does seem to be more significant. So this is data from a cohort of 201 adult patients with sickle cell followed at Vanderbilt University. And among these patients, the annual absolute change per year in FEV1 showed a decline that is similar to as what is seen in adult patients with cystic fibrosis. So that is to say there was no statistically significant difference in the annual change in FEV1 between adult patients with sickle cell and those with cystic fibrosis. So I just want to take a minute to really further highlight this discrepancy between lung function decline in children compared to adults. So in this graph, we can see that the red line is data from the previously discussed sleep and asthma cohort study showing an annual decline in children in FEV1% predicted. So this is the observed decline that we see. And if we extrapolate it out, we would expect adult patients to have an FEV1% predicted of about 85%. However, when we compare this to the blue line, when we look at two data sets, so the cooperative study of sickle cell disease, which is one of the largest adult sickle cell studies done, and then a more contemporary cohort of patients followed at Vanderbilt. So both of these cohorts, a mean age of about 31 and 32, we actually see an FEV1% predicted around 76, 77%. So you can see from the discrepant lines that there's clearly something happening, some sort of insult or change that's happening between the ages of 15 and 20, or maybe even later, that's causing there to be a really big difference between what we'd expect to see in lung function decline over time and then what's actually observed in adulthood. So overall, while we've made a lot of progress in understanding lung disease in children and adults with sickle cell, it seems that there's a lot of clinical questions to be answered to really optimize care for our patients. So just a few big take-home points. So first, asthma is associated with increased pain and acute chest syndrome in children with sickle cell. We know wheezing is associated with pain and ACS in adults. Atopy is associated with increased risk for acute chest syndrome in children with sickle cell. We know that abnormal lung function does not predict morbidity in children, but having a decreased FEV1% predicted is associated with mortality in adults with sickle cell. And then we know that lung function declines with age, but this decline appears much more significant in adulthood than what we observe in children. And then just thinking about some important questions and areas of focus to really help advance our knowledge and care of patients with sickle cell and airway disease. So first, how does asthma management alter the risk for future pain and ACS syndrome in children with sickle cell disease? What's the optimal strategy for addressing atopy, since we know this is such a significant risk factor, and how might this impact morbidity? And then what factors really contribute to a longitudinal decline in lung function, especially among adolescents and adults? And then how might this risk factor be mitigated? So thank you so much for your attention to this talk on sickle cell airway disease.